I think without question, it's very difficult to imagine the human condition without carefully considering the importance of the immune system in both health and disease. And for the purposes of the discussion today, immunology and oncology are our focal points and have shared an intertwined history in humans. However, it is likely not a coincidence that our ancestors, whom were albeit ignorant of detailed cellular and molecular mechanisms, could still appreciate at some level the dynamic interplay between health and disease. And it's only through the opportunity that we now seek to apply and manipulate the immune system in disease in an attempt to restore health to our patients. To better frame our discussion today, it would be helpful to know a bit more about your interests in immunotherapy. So please take a moment to respond to the survey that is appearing on your screen at this time.
Great. Well, thank you very much for that, Chris. We do have a poll question here on the audience members screen, and I encourage you to vote on this in real time by clicking on your screen. The question we have: what are your primary interests in immunotherapy? Your options are basic research, preclinical research and development, clinical development and or therapeutic application, or business development, or another. And you can actually select more than one option if you'd like. That question again: what are your primary interests in immunotherapy? Looks like most of you have voted at this point. I'm going to close polling now and share the results with you. The most popular answer was clinical development and therapeutic application. That was followed by preclinical research and development, then business development, then basic research, and just 2% of you said other. And with that, Dr. Learn, I'll hand the mic back to you.
Great. Thank you, Andrew. Appreciate that. Okay, so we have a lot of people interested in what will really be the true focal point today with clinical application. So to our next slide, you say you want to start a revolution. Well, you know, the good news is it's already underway. The war on cancer has been a bit slow out of the gates, but with the 90s came the advent of genomics, proteomics, kiniomics, and next-generation sequencing, to name a few, and so the battle is picking up the pace. Specifically, the various phalanx of the immunotherapy armamentarium are becoming more established and recognized as very real and credible opportunities to turn the tide in this war on cancer. And this is a welcome change, as historically classical cytotoxics have not yielded durable responses for our patients overall, while targeted therapies, which have offered glimpses of brilliant efficacy and responses at times, have been too far and in between in terms of repeatable success and are typically undermined by seemingly endless and very elaborate tumor mechanisms of resistance. But haven't we heard this whole song and dance before about right patient, right therapy, and right timing? Sure, and that is a fair critique here, and to date there's really no conclusive evidence yet that immunotherapy will be that next magic bullet per se. But what the data and proof of concepts in this arena have demonstrated so far is that we can feel more confident that immunotherapy is a dynamic and responsive treatment platform that is capable of bringing the fight to cancer on its own terms. And this is good. This is, again, an opportunity to treat differently and achieve better outcomes in a new way. So, what's with this enthusiasm? Well, there are many good reasons, say 10 quintillion, and I'm not trying to be funny or make a reference to my employment at Quintiles, but there are 10 quintillion diverse T cells and 10 sextillion diverse B cells in the adult human adaptive cellular immune repertoire. To put that into context, that's about the same number estimated for all the stars in the universe. So for all the chemical and molecular modifications tumors use to try to elude capture and destruction, T cells and B cells have a literally astonishing diversity in terms of specificity, and the ability to remember what they've seen and reconstitute the fight even faster next time around is all the more reason for some of that enthusiasm. And you thought your iPod was very powerful. Now, how can this diversity be harnessed and translated into clinical efficacy? That's a good question. there is some opportunity to vary the approach. And as you can see in this schematic, the key aspect is to cue activation of the immune system in a way that hopefully imparts specificity to a high-value target on the tumor and/or its microenvironment. And I think the real takeaway here is that while this graphic is busy, as we learn more about the immune system and how it can function when poked, prodded, and pushed into responding in the neoplasia setting, we could very soon add significantly more busyness, if you will, to the diagram here in the ways and opportunities to treat. Okay, so as you all have likely been waiting for, I should also discuss some of the dark side to all this sunshiny pomp and circumstance that I've been promoting for immunotherapy. Clearly, a single tumor can elaborate a cadre of mechanisms that can crash and burn the coordinated immune response in fairly short order. The ways this is done and the extent to which it is accomplished rivals, say, for example, the expansive diversity of the immune system we just finished reviewing and awing over. So on all levels, tumors are metabolic terrors orchestrating a systemic network of disease, likely far more sophisticated than the immunity that keeps the host in a state of health overall.